Good morning. I am Moshe Mittelman from Tel Aviv, and I am also privileged to be the chairman of the scientific board of MDS Foundation. And first of all, I would really like to take this advantage and say again, so big thank to Yasushi and to Seshi for a great meeting. It is a real pleasure, and I'm sure that I am echoing everybody. Second thing, we are going to have a patient discussion forum, and before that I would like just to say that as a young doctor, I remember myself coming back from meetings, local and international, and really feeling frustrated, because in the meeting things sound and look like quite simple. People are giving excellent lectures, excellent talks, things look fine. Even if you read the paper, things appear to be simple, but then you get to the first patient, and yeah, he does not respond to EPO, he does not want blood transfusions, the other patient has thrombocytopenia. No patient looks like the papers or like the talks. So the point here for the young generation, don't be frustrated. You will see that what you are having is what happens in real life. I'm privileged to be with us here, three experts. I don't have to introduce Yasushi, also Rafael Bejar from San Diego, and Amer Zeidan from Yale. And obviously there are many more experts in the hall. So with no more introduction, we would like to present the first patient for discussion. The first patient will be presented by Professor Yasushi Miyazaki. Please.
Okay, the first case is a 69-year-old male that his chief complaint was fever. Past history and family history is shown here. He was admitted to a hospital with fever in August 2017. Antibiotics treatment was started for suspected pyelonephritis. However, fever persisted. In October 2017, blood tests showed anemia and a few blasts in peripheral blood. White blood cell count was 5,950. Neutrophil count was 4,070. 1% myeloblast. Platelet count was 100,000. And hemoglobin level was 87. Bone marrow aspiration, myeloblast 6.2%, and dysplasia dysplasia of blood cells such as degranulation of granulocytes and megaloblastic changes. So diagnosis of MDS EB1 was made. Karyotype shows trisomy 1 and derivative 17 with deletion 20q. IPSS risk intermediate 2 and IPSS R risk and high risk. He was transferred to our hospital on October. This is the blood test examination. White blood cell count 6,000, hemoglobin 7.9, and platelet 270. And the CLP is elevated 15.8, and ferritin also elevated to more than 1,500. He has a little bit elevated creatinine level. Next slide, please. So this is the bone marrow aspiration at that time. You see the increase of myeloblast, degranulation of granulocytes, and megaloblastic changes. And the karyotype was, as I told. Moshe, do you get any questions? Okay, so, and this is a CT scan and showing both kidneys were enlarged, and the surrounding fat tissue showed increased concentration. This is compatible with the findings of pyelonephritis. So the first course, he has a lot of fever, the CLP, and antibiotics sometimes works but didn't work well. And then renal failure, renal situation got worse. And then again, the CT scan, you can see the multiple low density area in both kidneys. So diagnosis of acute renal failure due to antibiotic-resistant multiple renal abscess was made. So the urologist recommended nephrectomy both sides, and this is a pathological finding of kidneys. The finding of macrocytic and microscopic findings were persistent to pyelonephritis with edema and infiltration of inflammatory cells, such as lymphocytes and plasma cells in the renal pelvis, renal sinus, fatty tissue, and renal interstitium of both kidneys. In brown dark area, there are a cluster of neutrophils and abscess formed. Okay, so this is the following clinical situation. And
you want still the course?
Okay. Yeah, thank you. And after bilateral nephrectomy, fever subsided a little bit, but again, fever started. At that time, bone marrow blast was 4.2%, and there was no progression of mild dysplastic syndromes. And after that, pleural effusion, pulmonary infiltration, skin eruption started. Next slide, please. So this is a CT scan of the lung. And we have, at the left, you see infiltration and some nodules in the lung. But as a treatment was started, and after other treatment, this infiltration and bilateral pleural effusion, and these findings disappeared. Okay? Then, but again, he started to have fever, so prednisone was started. And sometimes fever got down with prednisone and azacitidine, but again, he started to have azacitidine prednisolone resistant fever. And next slide, please. And finally, he died of septic shock and respiratory failure. The genome sequencing shows genetic variants of DNMT3A, BAF 0.4, and CBPA, BAF 0.24. And of course, in the cytogenetic, he has trisomy of 1, chromosome 1. So you see the copy number increase in the chromosome 1. Okay, so clinical questions. When is the most appropriate time to start HMA in such a patient with very active infection? Because when he first diagnosed as pyelonephritis, we detected ESBL in his urine, and antibiotics worked at that time. The second question is, how do we differentiate infection from excessive immune response in MDS? This patient, at the later course of his clinical situation, his fever responded to azacitidine. The third question is, when should we have started HMA in this case?
So, in summary, we are talking about a patient with high-risk MDS, something which we are all familiar with, but situation is very serious infection, and the practical questions that come out are mainly, when are we starting treatment? Shall we wait and treat the infection first? Shall we start treatment? Without treatment, he will be in a bad shape. With treatment, he might be worse. So what should we do? Rafa, can you start?
Yeah, I mean, I can understand why this is a challenging question. If you have a patient who's acutely ill in front of you, obviously you want to do everything you can to improve their acute condition. And if you start treating them with azacitidine, that could be compromising. So the question is to try to establish the priority. and what's most important to treat first. My general impression from this case is that the infections were quite serious, right? This is a patient who actually had a nephrectomy for their renal disease, and that certainly would take priority, as it did with you as well, and then you bring in the azacitidine later. In general, I don't think of azacitidine as something that you would withhold in a patient at risk of an infection, but if a patient does have an active infection and the time isn't critical, I would do so. And then when I start it again, I might consider the likelihood of beginning some sort of antibiotic prophylaxis as I do if a patient has already demonstrated their propensity to become sick.
So would you say that you would have started AZA immediately?
Probably not. In this case, a person who has recurring fevers, the distinction is to make sure that they don't have an underlying infection that you might exacerbate by making them more neutropenic than they already are. So I would have the presumption that it's an infectious process and begin with some sort of antibiotic coverage. And only after I've really exhausted all sorts of infectious potential causes would I consider that this could be disease-related fevers and then begin with the azacitidine. Because if it is infectious and you do quell the neutrophil count, you can fool yourself into thinking that you've made the febrile syndrome better because you've treated the disease, but you may have made the febrile syndrome better because you've quelled the neutrophil response to the underlying infection.
Amer, how would you manage this patient?
Yeah, I mean, I largely agree with Rafa. I think a couple of points, I think this case is highly unusual. I mean, having treated many patients with MDS, this is not what you typically see in MDS, and usually waiting a week or two on HMA starting is not usually a big deal in the vast majority of patients, except in situations where they have a hyperinflammatory reaction. I've seen this where some patients might have HLH, that sometimes they have continuous high fevers, and it would not just go away until you give them steroids, IVIG, and start the HMA. But generally, I think it's not unreasonable to wait on the patient, a few weeks. This is someone with preserved counts with only 6% blast. He had an ESPL infection. Again, sounds quite unusual to need a nephrectomy. I've never had this kind of happen, but sounds like the abscesses were quite significant. So I personally don't think there was anything that was not done or was done incorrectly in this case. It's just that, it's sometimes these diseases are very tough to treat. I agree with Rafa on terms of the antibiotic prophylaxis. This is, I think, a point I always try to make, whether it's HMA or HMA-VEN, because somehow in AML, everybody prophylaxes all patients, but once it's MDS, it becomes we don't have evidence, it's institutional, I don't know what. But, those patients can get bad infections. And then the other point I would make in terms of waiting on someone with a bad infection is this patient started with a good neutrophil count. So if you have given them AZA, they probably have tanked.
So would you give your patients prophylaxis, prophylactic antibiotics?
Yeah, everybody, if I start HMA treatment, I generally will try at least antibacterial. I think
just when you start treatment?
Antibacterial, everybody.
And if you have such a high-risk patient before the infection, you have high-risk patient, leukopenic, would you give him routine prophylactic antibiotics?
If lower risk, I have patients who have ANC of 0.3 for years and they don't have any issue in the lower risk. So I usually will only start it in someone who's starting HMA treatment, and that's high risk usually, or in someone who had a previous infection, but I would not start it as a primary prophylaxis.
But you know the problem, you don't start antibiotics with 100 of them, but 101 would have severe infection, and then they come and say, hey, it was written on the wall. Why didn't you do that?
Again, this is highly unusual. I mean, it's unusual that you get such horrendous infection and kind of die from it, So here again, I think it was a judgment call that the patient was not continued, I think, on antibiotic afterwards. I don't think it probably would have made much difference. But again, it's tough to kind of, hindsight is 20/20, as they say.
Now, what about the second question of Professor Miyazaki? How to differentiate between infection and immune response, and does it matter?
Okay.
Rafa, what would you say?
Could you go back to the slides? I can't use it.
You want the previous one? No, this is the second patient.
This one?
Let me go back. Can we go to the previous one?
Okay. As I told you, we detected ESBL once in his urine. So I'm sure he had at least pyelonephritis, at least at the beginning. But you see the CLP goes up and down, green graph. So sometimes antibiotics work, sometimes didn't, but fever continued. So that may be, now if I think retrospectively, that may be a sign showing that this patient has a very inflammatory situation. However, because of the CT scan of multiple low density area here, it is very, very difficult to say this is not infection, just inflammation. At this point, he didn't have any skin signs or lung signs, so urologist said no antibiotics worked. We used many antibiotics, but it didn't work. So the final decision is nephrectomy. But we know that if we perform nephrectomy, he will lose chance to receive bone marrow transplantation. So that was a very severe decision, even for us, of course, for these patients. So how do you think, was it necessary or not? But do you have opinion to give as a cytidine with this CT scan? Will you? Or is it difficult?
Rafa?
No, I probably would not. I would definitely address a person who's got active infection with abscesses before putting on something that could be further immunocompromising. I don't think that making his MDS better was going to save him from this scenario.
Amer?
Yeah, I agree. I think generally you want to try to control the infection, but again, there are occasions, this happens with AML as well, where then you cannot control them. The people continue to have fever and you have to start treatment at one point.
I would like to take it. Yeah, Eva? Can you come to the microphone? We can hear you better. Not everybody can hear you.
So simple question. I mean, his CRP wasn't that high. It was lower than expected from a pyelonephritis. If I understand, it was around 40 or something. Did you check sedimentation rate, ordinary SR?
He did check what?
I think, yes. I think we can go back. Let me see. ESR.
CLP is 15.
No, not the CRP.
No, I don't see it. I see CRP.
Because, yes,
Oh,
and the
creatine-
CRP is not super high.
Yeah.
At first, his creatinine was 1.12, but after repeating fever and antibiotics treatment, he got into acute renal failure.
So in my sort of clinical practice hands, if you have a higher SR than the CRP, it usually speaks more for inflammation. And this, I mean, I find the CRP here is not a pyelonephritis CRP. Do you agree with me? It's low to be an acute bacterial infection.
Well, I'm sure this patient has inflammatory process, but is it part of the MDS, as we know, or is it part of the infection?
Yeah.
And practically, does it matter? I'm not sure. Remains open.
Yeah, I don't know how often it's used outside the U.S., but at least at our center, the infectious disease doctors often perform a precalcitonin test, which is often a good differentiator between infectious fevers and fevers of other inflammatory conditions, and we rely on that more than we do the CRP or other measures of general inflammation.
Can I ask, like,
Sure.
on the kidney biopsy or after, I guess, the nephrectomy, like, was there any cultures that were positive outside of at the very beginning when we had the ESBL in the urine?
Yes, at the beginning,
That's
ESBL positive
Just at the beginning.
at the beginning. But
Yeah.
after that, we continued to give him some antibiotics, so culture was not a good probe.
Yeah, I personally think if you have ongoing fever and you don't have any, despite multiple cultures and extensive infectious workup, I think at that point it could be the MDS.
Yes,
probably
of
started.
course, we thought about the renal biopsy, but the urologist didn't recommend to do that because there is a very dangerous chance to spread infection into the abdomen. Yeah.
Question?
No, one comment. So for this particular case, it has an unbalanced translocation. This particular case presents with infection, and usually these patients pass from infection-related causes. So I think that, well, it's a comment or a question, I guess. I believe that maybe the patient had an infection and it just wasn't subsided by any treatment that the physician treated with. So I believe that maybe HMA was would have been appropriate to be conducted much earlier because these clones would subside with HMA treatment, and then the infection would most likely subside. But that's just something that I thought.
Thank you. I apologize. I would like to go to another patient. I'm sure there are many more comments and many more questions, but as they say in the break later. I would like to present the second patient. Can we have the second patient? First slide, please. Okay. I would like to present a patient who is 68-year-old male with refractory anemia of the ring sideroblast and anemia. So this patient presented first, not to my hospital, to another service in July 21 with weakness, fatigue, which lasted for several months. He was anemic, high MCV, and there they did the biopsy and they established diagnosis of low-risk MDS, sideroblastic anemia, high serum ion, TIBC, ferritin 800, 20Q minus. And at that time in that hospital, they proposed follow-up. About a year later, a little bit more than a year, he became symptomatic. At that time, in the beginning, he was very mildly symptomatic. Then he became more symptomatic and started to develop anginal pain. Also had COVID, which he recovered from, had some kind of TIA. I'm not sure that it was a real TIA, but this is how it was reported. Hemoglobin dropped to about 6-7, and he started to require red blood cell transfusions. Erythropoietin was initiated, but unfortunately failed even the higher dose of 60,000 per week. And they also tried Aranesp, also didn't work. And at that time, he was transferred to our center. Obviously, he felt weak. His function deteriorated. His medical history appeared to be quite rich: arteriovascular cardiovascular disease, hyperlipidemia, obstructive sleep apnea syndrome, kind of seronegative rheumatic disease, peptic disease, and all trauma from his service. Obviously, he was in anxiety. I would have been as well. And he has a history of BRCA1 in the family, and he was a carrier as well. Medication list included all that you see here on the screen: aspirin, cannabis, omeprazole, statin, tranquilizers, analgesics, quite a long list. No smoking, no allergy, family history remarkable for breast CA, as I mentioned. Physically, mainly pallor and sinus tachycardia. Of course, he was anemic. And these are the other points. When in our center, hemoglobin was very low, 6, high MCV, a normal white blood cell count and platelet count, chemistry normal, high sedurate, EVA. CRP was normal, by the way. Sometimes we really see this separation. The CRP is normal and ESR high, or vice versa. Bone marrow was very hypercellular, 3 lineage dysplasia, blast percentage was low, ring sideroblast, 20Q minus, GI workup was negative. The diagnosis is clear. NGS demonstrated these mutations, ranks 1, TET2, SF3B1. IPSSM was low, minus, by the way, Amer, and the course. So initially, as I said before, the ESA failed, and obviously he needed red blood cell transfusions, 2-3 units per week. Hemoglobin was maintained at the age of 6 to 7.5, not really high. Hemolysis, there were some hemolysis parameters which were not clear about that, but the blood bank failed to detect antibodies, but we gave him for a while steroids, which might have stabilized the situation, but it's very minimal. And obviously, we considered stem cell transplantation, which he was not enthusiastic about. No surprise. In our country, luspatercept is not approved by the public service yet, and somehow Matteo Guillermo, we wanted to put him on the commands, but it was closed already, so he could not join the command and could not get luspatercept. But somehow he managed from his private insurance company to get luspatercept. So he started luspatercept, and you can see the table what happened. Very shortly, he started to begin to respond very nicely, and you can see that the hemoglobin, which was 7, and these are the blood that he received, then 9, 10, 11, and actually even now he is around 11. He did not normalize, but around 11, very nicely. He is happy. I am less happy, but it's okay. And this is the curve that you can see. And here are the questions about this patient who is now relatively stable, and what should we do now? Should we still recommend stem cell transplantation because we know that things are not going to be so nicely in the future? If so, should we do it now? Should we proceed with luspatercept, and only when he stops doing we can do it? You know the story about the lady who is asking her husband, why won't you pick the phone? And he says, it's not ringing, so why do I have to wait for the last moment? So shall we wait for the last moment, but then it might be too late? What is the significance of the 100% cellularity? What's the significance of FS3B1 mutation when it is isolated compared to when it is commutated with other? What's the significance of the BRCA1 in the family? What's the hemoglobin threshold for giving transfusion to patients, especially if he's a cardiac patient? So we have several questions for about 3 hours of discussion. But considering the time that we have, Amer, can you start?
Yeah. So I think your management was clearly very appropriate. This is, I think, a very good candidate for luspatercept. This is after ESA failure with SF3B1. The main issue is anemia, lower risk MDS patient, preserved platelet, preserved neutrophil. The only thing I would note is that this is somewhat unusual to get complete transfusion independence because he was very heavily transfusion dependent at baseline. Many of those patients on luspatercept will not get complete transfusion independence. You still get some reduction in the transfusion.
No, he's transfusion free completely.
He was getting like 2 units a week, right? So that's like almost...
now nothing.
Yeah, so that's, again, good for him. I think the second point I like to bring up actually is ranks 1 and the whole business with those classifications. This is actually a good case because according to the ICC, he has ranks 1 and he has SFRP1, so he would not be classified as, I guess SF3B1 mutated lower risk MDS. He would be low blast count MDS. And again, like this is a situation where I don't understand, the interaction between the prognosis, the classification, and treatment. You have a treatment, like why does it matter if the patient has ranks 1 or what, So I think this is one of the things that I think as a physician...
So I'll push you, what would you do?
I would continue luspatercept. I would not transplant this guy. I mean, luspatercept, if you have imetelstat, probably down the road, imetelstat, ESA, HMA, you could get several years out of this. And, he's 69. He was somewhat borderline.
He's very young.
He isn't like the young, marathon runner kind of. So I'm not sure he is a great candidate to begin with. But he's lower risk. You have a number of options. You could keep going with these drugs for a few years.
Yasushi, maybe you would like to address?
Okay, I will not transplant either. I agree with Amer because his IPSSR risk score is low risk, And he also have some comorbidities like a rheumatoid disease and some background mutation of his family has a BRCA1 mutation. So that may have some impact on the results of high-dose chemotherapy or radiation therapy. So as long as he's good responder to luspatercept, this situation seems better.
So you are not enthusiastic about stem cell transplantation. So one day he comes and he tells me that he had a very important second opinion consult, Dr. Google. And then he comes and tells me, what's my future? I have a very bad future. He's not enthusiastic about stem cell, but on the other hand, he is concerned about his future.
Mm-hmm. Yeah, but the future can be shown by using the IPSS-M risk score, which predicts his long-term outcome. Seems better because thinking about his situation and his age, the transplant-related mortality will not be 10% more than that, I'm seeing.
Maybe for Carmelo.
Yeah, it's just a very curious case. Thank you. So I wonder if you have information about this red blood cell morphology, and I explain you why. So there are some cases of deletion 20q that are linked to hemolysis, and this has been linked to deletion 20q and acquired erythrocytosis. So that might trigger the hemolytic parameters to be indeed positive, like in this case. These are usually male, elderly, with deletion 20q, hemolytic parameters, and a very indolent course, like the one that we have in front of us. So this may be also like perhaps an argument for not proceeding to bone marrow transplant, for instance.
I looked at this peripheral smear, but not in the beginning. And when I looked at it, it was after many red blood cell transfusions. So it was difficult to say whether I saw, fragments of cells and anisopoikilocytosis and spherocytosis. But I could not say whether it is related to the blood transfusion that he received 2-3 per week,
right,
or with what is the natural occurrence of the disease. I could not say that.
Yeah, just like an observation.
Yeah. Rafa?
Yeah, I concur with my other colleagues here. I would not transplant him right away. I think that you have a patient who isn't blasting off. He's not headed directly into leukemia. He's got a low-risk profile. So you have time, I think, to try to buy him some good quality of life, which you've already done with the luspatercept. I would, however, think that a patient like this, if they needed a transplant in the U.S., would be very likely to be considered a candidate despite the comorbidities and the other marks against them, including the elevated ferritin and other things. So in my opinion, he would be seeing a transplant at some point in his future, and that could be well into his early 70s as well.
He was already seen by the transplanters. Of course, they are very interested in proceeding, but we are holding it, absolutely.
So what I would do is I'd keep him on the luspatercept. I'd consider beginning iron chelation in a patient with a 1500, just not so much to prevent the iron-related toxicities, but more because there is some evidence to suggest that elevated ferritin does impair the outcomes after transplant. And now that he's not transfusion dependent, it might actually be an opportunity to reduce his ferritin.
Amer, what do you think about the 100% cellularity?
Yeah, I think that's clearly supportive of the MDS diagnosis. I actually was going to make the point for Carmelo's question. At the beginning, before you have the SF3B1 mutation, when this patient had ring sideroblast and only deletion 20q. So this is not diagnostic. Deletion 20q is not diagnostic of MDS by itself. It can happen, you could have it as part of the isolated chromosomal abnormalities. So I think this is a situation, if I did not have the SF3B1, I would make sure this patient did not have copper deficiency, did not have alcohol history, because certainly these patients I have seen patients with copper deficiency who get started on HMA in the community before anybody checks for copper deficiency. But once you have the SF3B1, I think it's, it clearly becomes very clear-cut lower risk MDS. But yeah, I don't make too much of the cellularity. I think it's part of the MDS. And I have to say again, I think we always say that transplant is the only way to cure, any kind of MDS, and patients hear that, and sometimes they, as you said, they are focused on that aspect. But I think it's very important to give the patient a realistic picture of the short-term and the long-term complications and, the chance of GVHD and all of that. So I think you really want to paint a very good picture of what can happen with transplant as well, especially if you are not in a rush to take this patient.
But let's go back to the SF3B1 issue. Do you really distinguish between those who have isolated and those who have additional mutations?
I don't think you have to do it at the classification level, and I agree with Amer that's somewhat arbitrary what you decide to include into that group. But I look at the consequence of having that mutation, and if you apply the IPSSM to this patient, this is a fun exercise to do. You put in the mutations and you see where the prognosis lands. This person is actually on the moderate high side after you put in those counts prior to luspatercept and put in the other values. And you can then remove the RUNX mutation or remove the SF3B1 mutation and recalculate. And in the presence of the RUNX1 mutation in this patient, the SF3B1 loses all prognostic significance. The prognosis is driven by the RUNX1. It's only in the absence of RUNX1 that SF3B1 becomes favorable. So I do consider that to be an important predictor of the patient's outcome. And in the same discussion that Amer would be having with him about the risk of transplant, I think he has to understand the risk of not having a transplant.
Now, Yasushi, what do you think about the BRCA1 in the family? Does it make any difference? Would you behave this patient in a different way? Do you link it somehow?
Well, so far we do not have a lot of information regarding the BRCA1 mutation on the prognosis or the clinical course of MDS in the male patient, I mean. So, but considering the function of BRCA1, as I told you, high-dose chemotherapy or radiation therapy be harmful than ordinary people. That's easily understandable. So that's going to be one of the reasons not to transplant right now for this patient.
Last point which I would like to discuss is the hemoglobin threshold for transfusion. This patient really required 2-3 units per week in the worst time, and the hemoglobin was maintained between 6 and 7.5 no more. What could you say about this and other patients regarding hemoglobin threshold for transfusions? Amer.
Yeah, this is a question that doesn't have an answer from randomized trials. I think different institutions and different people use different thresholds. I tend to use hemoglobin of 8 as outpatient and 7 inpatient. I have seen actually some countries, I was talking to colleagues in China, and they use hemoglobin of 6, which is the lowest I have heard. I don't know what do they use here in Japan, but this is actually an important consideration when we even design trials that look at transfusion independence, because there's a huge variation. But this is a good example of the things that can happen with transfusion. This person is alloimmunized. He's not going to be able to go much longer with just transfusions without intervention.
Rafa?
In a case like this, I would look closely at the hemolysis question. I think Rami has shown that U2AF1 mutations are also associated with spontaneous non-immune hemolysis. It's very difficult to manage. And my practice is generally to try to transfuse patients to a higher level. And I think Eva mentioned this yesterday, that if you give a few extra transfusions to get them there and then maintain them there, you're not really giving them more blood than you would have otherwise. You're just keeping them at a higher level where they're less likely to be symptomatic or have complications of severe anemia. So that would be my approach. Dr.
Wlodarski?
Just one comment. As a pediatric hematologist, don't you feel miserable with hemoglobin 7 to 8 long term? Yeah. I mean, it's a different story when you have ALL, you're treated with chemo for 3 to 4 months, you have low hemoglobin, and you can have the threshold of 7, right? Or you have an orthopedic surgery or something, you can use the threshold of 7. But I think obviously there are no randomized trials because that would be unethical. But from the pediatric perspective, we have the new Diamond-Blackfan anemia guidelines that are coming out in Lancet Hematology, and we propose hemoglobin of 9 to 10 long-term, also in adults, like lifetime, because you cannot function with hemoglobin of 7 to 8, right? It's very difficult.
I think even if you accommodate, there are long-term consequences to doing so, and I think those are starting to be shown that even moderate anemia can be more significant when chronic for that degree of time.
From the body language, I'm sure that Eva has a comment. I'm sure. At least I'm good in physical diagnosis.
So we actually made, many years ago, we made a small randomized phase 2 study, transfusing patients at 2 different levels. It's not a large study. It's not a major scientific finding, but we did find stable quality of life at a higher level in those that were transfused. At that time, we had 12 versus no specific sort of target. So I definitely think that you have to ask the patient, and patients are different. They can tell you what
Yeah, we
kind
have
of
to ask them
level
how they
need.
feel. Yeah, I agree.
You don't need to do this top down.
Yeah,
This is what I'm saying.
I agree. Well, with the interest of time, the last comment to the host, Yasushi.
Yes, in Japan, the recommended threshold of transfusion is around 7, 8 for chronic bone marrow failure without comorbidities. With comorbidities, of course, it's different. But so the threshold of blood transfusion is significantly different between Japan and other countries. That's the real situation.
Thank you. Well, I'm sure we have more questions than answers, and still open questions, but I realized that people might be hungry. So we will close the session. Thank you so much, Yasushi, Amer, and Rafa, and thank the organizers, and have a bon appetit.